Okay, perfect.
Hello and welcome to today's webinar delivered by Dr. Anangsha Kumar, who is a specialty trainee in Obstetrics and Gynaecology based in Wales.
Okay. Hi, I'm Anangsha. I'm one of the, as she said, I'm one of the ST1 trainees, going to be ST2 in August in Wales. So just to get an idea about the audience, is everyone a final year med student about to start their F1 rotations? Am I right in saying that?
It's a mix with majority med students and the occasional one.
Okay, perfect. Okay, no worries. So in obstetrics and gynecology, most of the common conditions as well as the emergencies, it requires a bit of a senior input as in any specialty. But as a junior doctor, I think there is certain basic things which your seniors would be expecting from you. And today I'll focus rather than going into the theory, because most of you, I don't know what specialty you'll be going in, but what I'll be focusing on is what is absolutely necessary as a foundation year doctor or as an SHO in an obs and gynae ward, how to deal, how to manage those patients, how to present the case in an SPAR format to your seniors rather than going into the pathophysiology or the exact management which will be dealt with your seniors. So to begin with, I'll just start with the common conditions. So in the common conditions, I've subdivided it into obs and gynae. So to begin with obs, in a triage or in your antenatal ward, mostly the patients will be coming in with the following complaints. It's really rare that somebody will be coming in with something else. It can happen, but mostly you will be having your seniors to support you for that, even in these situations as well. But these are the most common ones. So to begin with, generally, the first one which I will be discussing will be abdominal pain. Sometimes we refer to it as SPD, which is symphysiopubic diastasis. I'll explain what it is a little later. But just to begin with, if a lady comes in, suppose she is 22 weeks pregnant with some abdominal pain, generally she'll be triaged by the midwife, and then she comes to you. The midwife bleeps you and asks you, okay, fine, she has come in with some pain, so what to do? So what you would do is you'll take a thorough history. So in obs and gynae, if you follow a format like a pro forma, it just makes your life a little bit easier. I generally follow a mnemonic so that I don't miss out on stuff. I haven't put down the mnemonic here, but if you guys are, because most of you guys will be familiar with it, but I'll go through it with you. It's the P7 maftosa. So first will be presenting illness, then presenting complaints, which is your history of presenting illness, then past history, present history, and the other 4 Ps will be smears. Just ask them about their previous smears. In cases of obs, you don't need to ask, but you can, in gynae, you need to ask about their periods, how are their menstrual cycle, about contraception, and about anything else, which is the other P. So these are the P7, and the maftosa will be medical conditions, allergies, family history, any travel history, which is very important in OBS, occupation, what do they do? Because waitresses will generally get a lot of symphysiopubic diastasis as compared to others, and those who stand for a long time. Then you can ask for social history, which comes in the personal history as well at times, about how much she drinks, if she smokes, and A is anything else. So if you follow this format for any obs and gynae history taking, I think that's quite thorough, and it's hard to miss out on any history bit of the patient. So if a patient comes in with some abdominal pain, you can always take a thorough history and examine yourself. The midwife will do an abdominal palpation, but just make sure what you feel. Is the baby breech? Is the baby transverse lie? What it is, because it will change your management, rather your registrar's management plan quite a lot. And once you examine, just see if she has got any bruises. Is there a case of trauma that is that she has maybe missed, and for that she might be having pain? Is there any tightening? Sometimes tightening is contractions of the uterus. It can be false labor pains or true labor pains. Towards the end, it will be true, but before that, it's more like false labor pains or Braxton Hicks. So you need to feel for yourself rather than just relying on the midwife or, in fact, the CTG. You examine the patient by yourself, see if she is tightening clinically, and correlate your clinical examination with the CTG findings of tightening. At this stage, when you start off your F1 rotation, nobody will expect you to interpret a CTG. Even in my ST1, I was learning how to interpret because it's a whole vast topic in itself. So telling you how to interpret CTG will not be done in an hour or two. It takes weeks to like months for me to know. But the midwives are always there to help, and you can always feel rather than going for the clinical graphical interpretation of the CTG. If at all you feel it is necessary, don't do unnecessary speculum or vaginal examination. It just increases the chances of infection. So do a speculum examination if you feel it's necessary in order to rule out bleeding, because sometimes with trauma, there can be a little bit of bleeding as well. Give her ibuprofen, just don't give, give her analgesia, just don't give ibuprofen. And make sure these ladies can, I have realized after I started my rotation, how important safeguarding is. It's something we all miss out. But then again, in cases of abdominal pain, hyperemesis, these are the situations where ladies often come in with repeated admissions. And we realize later on that there is an issue of domestic abuse going on. So make sure of that. So what are all are your differentials for abdominal pain? Yes, it can be Braxton Hicks, which is false labor pains. It can be UTI as well. So get your urine dip and everything done. If you find nitrates, leukocytes, send for an MSU. And then depending on what trimester she is in, just go for the antibiotics that I have said here. It's just because certain antibiotics like nitrofurantoin can be teratogenic in the third trimester, whereas cefalexin is not suited in the first and second trimester. Just start off, even if it's asymptomatic bacteriuria with not classical symptoms of LUTS, just go on, give her the antibiotics, and then when the culture and sensitivity comes back, you can always change and shift to other something else. Just to highlight a bit, asymptomatic bacteria is very, very common in pregnancy. So just make sure that if it's UTI, you just treat it if your urine dip comes positive. So a lady coming in with abdominal pain, your top differentials as a junior doctor will be either any trauma or she has any tightenings. If there are any, if you cannot interpret the CTG, just go ask for help, ask for your band 7 midwife or your registrar to have a look to make sure if she is tightening regularly. And by regularly, I mean each contractions lasting for a minute and 3 to 4 of that in 10 minutes. So if that is the situation, that means she is heading towards labor. In your history, just make sure you ask that lady that how her previous pregnancies has been. As I asked in P7 Meftosa, there is past history as well. So you ask her about her previous pregnancies. Has she had quick labor? Has she delivered in the car park? Has she delivered while going for shopping in Tesco? Like some ladies deliver in like 3 or 4 hours. That's their duration of labor. And if she is a multip, then it's quite likely that she'll quickly go into labor. So just make sure you ask about that, and then you present whatever your findings are to your registrar or whoever your senior is in a very good SPAR format. If you take your history in the P7 Meftosa format, do the examination, give her some relief, pain relief, ensure the safeguarding issues. If it's UTI, it's something they would expect you to manage by yourself. If not, if it's something which is like progressing labor, then just hand it over to a senior midwife and ask her to shift her to labor ward. So the other thing which you can manage and which is very common in abdominal pain is symphysiopubic diastasis. So what happens in this scenario is, as the womb is growing with the growing fetus inside, the veins get engorged, and as a result of which the symphysis pubis, it gets stretched with the ligaments, and that causes a lot of pain in your symphysis pubis and causes venous engorgement as well. And that's what we call as an SPD or symphysiopubic diastasis. So in that case, the best thing you can do for the lady is, I know it sounds really simple, but it works wonders. You can just ask for some hot fermentation and give her some good analgesia to go home with, some codeine, and she should be all right. So rule out your differentials. Make sure you make a very good list of differentials for your abdominal pain. And if it's something simple, go ahead, treat it. If not, then just ask for a senior review and I think you'll be sorted. Any questions here for abdominal pain? Because it's very common. Everyone will come, like in the middle of the night while you're in your shift. I think people will come in with abdominal pain. These are like the most common differentials which would come: UTI, Braxton Hicks, then trauma, or actual labor, in fact.
No questions in the chat. Just carry on. Thanks.
Okay. The other thing is altered fetal movements. That's another very common lady coming in with 3 episodes of decreased fetal movements, or second episode of decreased fetal movements, or even the first. Again, take your history in a very good format and ask her about how frequently has she previously felt the movements, and has it changed? So if you know how her pattern is, some ladies will be referred by the community midwife because the baby hasn't moved for 24 hours. But if you ask her, she would say that, okay, it's my first baby and my baby hasn't been moving that much. She just moves probably once in every 2 days and at night. And in first trimester, it takes a little while to feel quickening, which is the first movements of the baby. So it's around 18 weeks onwards, but then again, it just varies. You cannot put a date to it. You cannot put a particular gestational age to it. It varies from one woman to the other. But then again, you have to rule out for certain red flags. Is there any discharge with these decreased movements? Is there any spotting, any PV bleed, or anything unusual? If not, then well and good. Just ask the lady to go in for monitoring of her CTG and make sure that there is a criteria which we call as it's an electronic criteria where the computer analyzes if it is meeting the particular requisites of that gestational age of the lady, which we call as a Dawes-Redman criteria. So it's mostly common in antenatal CTGs. I'm sure if you have done your F1 rotations, if some of you have started, you might have come across this Dawes-Redman criteria as well. But then again, Dawes-Redman is not ideal. Like, it's not the only thing to look for. You need to interpret the CTG yourself. I'm not saying you per se, but make sure somebody senior who has a clear idea of how CTG works knows that how the CTG is. And if it's something not reassuring, then that needs to be dealt with. Generally, it depends from trust to trust, but in Wales, it's if there are 3 episodes of decreased fetal movements, we do request an ultrasound scan with an amniotic fluid index and Doppler. If it's within like 2 weeks, because we don't repeat growth scan that frequently. So you can do a growth scan as well. If you have the facilities, the funding and everything, you have to make sure of everything as well. But generally an ultrasound scan with the amniotic fluid index and Doppler should be okay for these ladies with decreased fetal movements, because then you get to know that how is the RI, the resistive index, the PI. So these will give you an idea of whether the blood flow, the placental blood flow to the baby is adequate or not, and if the growth is being healthy, if you at all manage to get a growth scan. Discuss. If you have decreased fetal movements, you're not quite sure about it. There are certain values for RIs and PIs. I don't know if you guys have come across this chart. So according to the gestational age, it generally needs to be under the 90%. It's very clear if you guys come across in your antenatal clinics, in your day assessment units, it's readily available according to the, so that's the amniotic fluid index and Doppler, that's the Doppler bit of it. So if you see that it's within range, okay. And if you know how to interpret it, those charts, then you are safe. So this is the RI and PI chart for the blood flow to the umbilical artery and everything. But yes, if you're not too confident, just ask for help. Generally, you need to see for any signs of oligohydromias as well. So generally 2 to 8 centimeters is normal. Anything over 8 is regarded, it's considered as more for deepest vertical pocket. And you also see a deepest vertical pocket for the amniotic fluid, sorry. And you also need to see the amount of fluid, if it's normal, if it's more. If it's more, then sometimes it's quite common for ladies not to feel. If the lady is obese, it's quite common for her not to feel the movements of the baby. So you can sometimes correlate with the ultrasound features of amniotic fluid index and Doppler and her clinical picture of what the reason for decreased fetal movements are. So as a junior doctor, what you need to do is monitor the CTG, because at the middle of the night, you might not be able to get an ultrasound scan with an AFI and Doppler. So if the CTG is reassuring, send her home, organize a scan for her with an AFI and Doppler, or if possible, get a growth scan on her. And that's it, just send her home. But if she is not, sometimes while she is on the CTG, she'll say, okay, the baby has started moving again, send her home. But if she is not happy, never send a lady home if she is not happy with the movements of her of the baby movements. Keep her in, monitor CTG every 4 hourly, and just make sure that you are happy, because the most incidences of stillbirth and IUDs I've seen with ladies coming in with episodes of decreased fetal movements or absent fetal movements. So if the lady is not happy, keep her in. If you are not happy, keep her in. A CTG is fine. You might not be able to get a Doppler with an ultrasound scan overnight, but with a CTG which is reassuring, I think you'll be good. So that was about altered fetal movements. Any questions for that?
At what point would you escalate to your registrar or consultant after your initial management?
So in case of decreased fetal movements, if I find that the CTG is not reassuring, by not reassuring, if I see that there is no variability. So for these things, you need to know the CTG really well. If you see that there are no accelerations, presence of, so these are the 3 things you need to see. No accelerations, presence of decelerations, no variability, no cycling. These are the things I am concerned about, and I would escalate to my senior that this CTG is something I am absolutely not happy with. So in that case, I need a senior review to make a plan for this lady, because she might need a delivery. Or she might need a tertiary care support, because in your, I don't know what setup you're working in. So if a CTG is not reassuring, that is actually a term, then you escalate to your seniors. Another thing, if you don't know how to read a CTG, your midwife or the senior triage midwife will know. If she says she is not happy with the interpretation of the CTG, then you do escalate as well at the same time. So if you know how to interpret a CTG, the 3 things which you look for is no accelerations, presence of decelerations, and no variability. So if there is no the variability is generally 5 to 25 beats per minute. If there is no variability, then it's something concerning and you need to escalate as well.
Thank you.
No worries. So the next thing I'd go on is spontaneous rupture of membranes. So not always the ladies who say that they are having spontaneous rupture of membranes will actually be having spontaneous rupture of membranes. They just feel, if there is an exacerbation of discharge, they sometimes feel, oh my God, my waters have gone. It's not actually the case. So just make sure that you examine the lady and yes, prioritize her present, like whatever she's saying and her symptoms, definitely, but see for yourself and say that, okay, I do appreciate. She'll be saying, okay, I'm soaking pads, I can't like I can't even stand up. It feels that I'm passing urine the moment I'm standing. So definitely my waters have gone. Usually they are right, but make sure you examine the lady yourself. So in this case, what you need to ask her, apart from the P7 maftosa, is when did she break her waters, if at all it did? What's the color? Because you need to know if that water is greenish in color, because then you're suspecting meconium stained, isn't it? So that's something which requires escalation as well, because they wouldn't expect you at your level to manage a lady who has SROMD, which is spontaneous rupture of membranes, with MEC. The amount, how much fluid is she leaking? And that's it. Just do her observations, see if she is spiking a temperature, do her routine like temperature, blood pressure, and all the things in the Muse chart, and put her on a monitor. Put her on a monitor, because generally, whichever lady comes to triage or antenatal ward, if it's a direct admission, they will automatically put her on a monitor. So if you can read the CTG, just make sure that she is, if it's an antenatal, she'll be on an antenatal CTG. So she see if she meets the Dawes-Redmond criteria. Look for the 3 signs, as I said. Presence of accelerations is good, reassuring. No decelerations is good, reassuring. Variability of 5 to 25 beats per minute is again reassuring. These are the 3 signs at your level. If this is something you know, I think it's more than enough. Do a speculum examination. See what the situation of her cervical os is. If you're not very competent with your vaginal examination of how dilated she is, do a speculum. It will give you a clear picture of what's going on. We sometimes do a test, which tests a particular protein in the fluid, amniotic fluid, and here we call it as an amnesia. It's very common. You will come across. It's of various names. Sometimes we test fibronectin. It's called amnesia. It's basically the brand names, which tests this PAMG1 protein in the cervical canal, which is present in the amniotic fluid, basically. So it gives you an idea of whether the lady has actually broken her waters or not. If you feel that it's not necessary, you feel that it's like a discharge, sort of a curdy white discharge or a mucousy discharge, or maybe she has lost her plug and not even broken her waters, take swabs. Take a high vaginal swab for her, send her. Most of the ladies will come out to be GBS positive, like a lot. We sometimes underestimate the incidence of GBS, but it actually happens quite common in pregnancy. And some ladies might come in with bacterial vaginosis as well, with heavy discharge. It's very common in pregnancy, and the incidence increases exponentially of bacterial vaginosis, especially in pregnancy. So just make sure you take some swabs. This PAMG1, which I said available in the name of Amnesia, at least in Wales, and it can be of different names as well. So it just gives you a test of whether it tests this protein and gives you a result of whether the lady has broken her waters in 5 minutes. So literally in 5 minutes, you'll know whether the lady has broken her waters or not. So why do I need to know that whether she has broken her waters? What are you going to do? What you're going to do is, if she has broken her waters, it does not necessarily mean she might go into labor immediately. It depends on her previous pregnancies. But what you might need to do is you might need to consider an antibiotic coverage. generally erythromycin sometimes you consider. Not all the trust will say, but if the lady has broken her waters, depending on her clinical picture, depending on her infection markers, it's considered safe to give her a course of erythromycin for 7 days at least, and then just stop. That's fine. She can go into labor in a month's time, in 2 weeks' time, in a week's time. And if you feel these ladies, you can generally send them home. You really do not necessarily need a senior input. But if you any obstetric it's a high risk specialty. So if you at any point feel you need support, just go for it. Just ask them for help. And I'm sure they'll be happy to advise you with this. So SHROM is pretty much fairly simple, other than the history taking and the detailed details of how she has SHROMed. If you do the speculum examination with some swabs and testing for an amnesia, if it's available in your trust, and giving them a good antibiotic coverage, I think you should be all right. Just make sure if they are spiking a temperature and everything, you do the sepsis bundle, which I'll cover in sepsis as well. So this is actually pretty straightforward in obstetrics, in amongst the common conditions, and it's fairly simple. Ensure her CTG is reassuring before you send her home. Don't send her home with a CTG where she is contracting 5 in 10, because probably she's going to go in labor pretty soon. So just make sure before you send her home, safety net her well about any decreased movements of the baby, any signs of increased contractions of 3 to 4 in 10 minutes. As I said earlier, just ensure you highlight all these red flags and ask her to come back to the hospital. Before you discharge any patient, safety net the patients really well and document it in your notes that you have safety netted her well and asked her to come back in case of any concerns. So that's spontaneous rupture of membranes. Any questions? No, I guess. So my favorite topic, pruritus, which was obstetric cholestasis. So this is a topic really close to my heart. I love reading, writing about it, and that's why I have put it. And after going to Wales, they say that obstetric cholestasis is present in 2% of the UK population. Trust me, I have seen more obstetric cholestasis than 2%. Like Catherine Williamson, she is one of the maternal medicine professors who has a special interest in obstetric cholestasis, and I've personally spoken with her that it is definitely more than that in Wales. And sometimes that's why it's very important to ask about the profession, because we have seen, me personally in Wales, it's a farming population. I have seen a lot of women coming in with obstetric cholestasis, like every day. If I'm on call in a week, if I'm on call for 3 or 4 days, I would at least see 5 to 6 cases of obstetric cholestasis. Trust me, that's quite a high number. And it's just in my shift. So it's night shift is there, days I'm not on call. So it's very important. It's very distressing for the patient, and it needs utmost importance. Sympathy, empathizing, treat her, give her support, do all the tests. It's really important. These ladies event can sometimes even commit suicide with obstetric cholestasis and pruritus. It's very, very distressing. I cannot highlight it enough. Give them some Piriton before you start seeing them and taking a history, because they'll scratch themselves to death. And so give them Piriton before you start taking a history and doing all the examination and everything. Blood tests, very important. Do the bile acids and the series of LFTs. So in any management of obstetric cases, however, so there is nothing common conditions. I think anything can pretty much take a rapid turn and become an emergency at any point of time. Please do follow the hospital local protocol, which is there. Every hospital will have a protocol. So these are the basics which every one of these clinical conditions entails. So that's what I have highlighted, but do ensure that you strictly follow the protocols as well. do the bile acids, do the LFTs. If the bile acids are raised, fine, diagnosed, obstetric cholestasis. Start her on ursodeoxycholic acids and just commence her on that and give her like 200, depending on, you can give her BD, TDS, depending on how severe it is. And then again, your trust protocol will be able to guide you with the like frequency of the medication as well. If her bile acids are fine, but her ALP is raised in pregnancy to 3 times, don't be alarmed if the ALP is raised. It's the ALT and the AST which matters. So if it is raised, then you have to rule out other liver pathologies for these ladies as well. So what do you need to do? Do a hepatitis screen. It is not one of the common screening which is done antenatally. Do the hepatitis screen, do a liver screen, do the antibody screen. There are like anti-muscle antibodies, anti-nuclear antibodies. Do a thorough screening. It will cost nothing, but it will at least give you that reassurance that fine, she is clear from the liver pathology point of view. Once you send the LFTs, you'll obviously take an FBC as well. Rule out HELP syndrome as well. She might not be symptomatic, but you will find out that she has elevated liver enzymes. And when you have a glance at the FBC, you'll find that she has low platelets as well. And then she will start saying, because the itching is so distressing that she might not even see her blurring of vision, frontal headache, epigastric pain, pedal edema. She wouldn't be able to appreciate that because the itching is so much. So just ensure that if the bile acids are normal, but your LFTs, which is the ALT and the AST is raised, ensure that you rule out any liver pathologies for that. Discuss with your seniors. This is something which definitely, again needs discussion with the seniors, because if it's too distressing, sometimes we do consider delivery from 36 weeks onwards. So she does need a plan for her delivery. I'm not saying by plan of delivery, it always necessarily needs C-section, because that was initially, as a junior doctor when I was an F2, that was my idea. No, it can be like normal vaginal birth as well, but she needs a plan. Whether she needs an induction of labor from 36 weeks, she needs a plan for that. If it's too severe, her ALTs, her bile acids are just off the charts in spite of the URSO, that needs addressing. So a lady coming in with itching, just make sure that it's not itching with rash and she's not coming in with chickenpox or something. If it's most commonly, it's obstetric cholestasis, and it's common in repeated pregnancies. You'll see that if a lady has obstetric cholestasis in a previous pregnancy, the chances of getting obstetric cholestasis the next pregnancy increases rampantly. So after you rule out all the other causes of like anaphylaxis, allergy, not that common, and like chickenpox and everything, if it is actually diagnosed obstetric cholestasis, do your bile acids, start her on URSO, make her a plan of delivery if it's quite intense. If not, if just the LFTs are raised, which is the ALT and AST, just go to rule out all the other liver pathologies. So that was obstetric cholestasis. The other thing is, what I'll do is, since I think I'm running out of time a bit. Am I right in saying that? It just shows
yes.
3.
I have a few.
Yeah, so I'll
left, but then we'll reopen with the other link.
Okay, fine. So it's the other one is PV spotting and gestational hypertension of preeclampsia. PV spotting, it's pretty much fairly simple. You again rule out, as I said, for SHROM and trauma as well. The only thing I'll highlight here is just make sure it's not a low-lying placenta or a vasa previa, or she does not have any previous cervical ectropion, because then that tends to exacerbate in because of the vaginal engorgement of the vaginal vessel, vasculature and everything. It tends to exacerbate even with the minor trauma. Ask for recent sexual intercourse, because that sometimes can cause vaginal PV spotting as well. But the most important which you need to look out is to rule out any placental anomalies, which is the low-lying placenta or vasa previa. And if at all needed, she needs a plan for delivery if she is bleeding really heavily. And obviously, CTG is mandatory. Obstetricians, they love CTG. So yeah, just make sure. Now coming on, I've put on preeclampsia and eclampsia in my emergency bit as well. But again, just ensure that you, if a lady comes in with the clinical symptoms of, as I mentioned in health, of headache, a blurring of vision and everything, if it's 140/90 in 3 episodes, just check manually. Check the clonus reflexes, very important. Send for a urine PCR, send off the PET bloods. And if she is diagnosed, commence her on antihypertensives, please, labetalol. But ensure when you will do her history taking, make sure she's not asthmatic, or you don't start her on a labetalol if the lady is asthmatic. Start her on nifedipine instead. If you can't start nifedipine, start on alpha-methyl dopa. These are the antihypertensives which are commonly preferred in pregnancies. If she's diagnosed preeclampsia or gestational hypertension without any proteinuria, that is, which we call gestational hypertension, she needs serial growth scans. So as a junior doctor, make sure she gets these scans done. If you're seeing her at 24 weeks, make her a scan appointment for 28 weeks. The rest can be dealt with in the clinic. Ensure that when you are discharging her home with antihypertensives, make sure that the community midwife checks her blood pressure thrice or twice weekly with a repeat of her bloods as well, the PET bloods. So that was the common conditions of obstetrics. Sorry.
Thank you very much.
No worries. The gynae common conditions aren't much, so I think I'll cover them in the emergency bit as well a little bit.
Okay.
It'll just take 5 minutes.
Okay, we have the second link. If you don't have it available,
Okay.
it's also going to be on the Instagram homepage within the next 5 minutes. So we'll see you in a second. Okay.
Okay, perfect. Thank you.